Bob Levy, a voice or a picture from the past.
Barry Casson, looking handsome as ever.
Yeah, the white hair frames me.
Yeah, it's getting a little thin up here too, I'm afraid. You know, what can I say?
Yeah, it's part of the way it goes.
Yeah. Okay. Well, at least I'm following in reliable footsteps, right?
Well, in footsteps anyway. So you're not presenting, correct? It's or are you presenting?
No, I'm not. I'm just an audience.
Monica?
No, it's Justin Gill.
Justin. Okay.
Oh, I wasn't sure which Jay Gill. Yeah, that's good.
In the transplant, there's a number of Gills, including some patients. So I guess is Justin, let's see, he's not here yet. Bob, how are things going?
Just living the dream. How about you?
Oh yeah. Yeah, every day. Every day's better than the next.
That's right. No, I hear it's almost over, so we're good.
Well, hold on. What's almost over?
Not everything.
Yeah, I'm not sure that I'm going to celebrate.
Things are good. Things are good.
There are things that I'd like to be over, and other things that I'm celebrating they're not over.
Okay.
There's Justin. Justin.
Hello. How are you?
I'm good. How are you?
Good. Nice to see you again.
Nice to be seen. So is your talk a full hour, or can we start a little bit after?
I think it may be, but we can wait a couple minutes.
Okay. Well, it's just before, maybe if we start just a little bit after, the starting time.
Sure.
And we're talking about transplantation, correct?
We are, yep.
Monica, did you want to introduce Justin, or do you want me to?
Up to you, either or.
I'm happy to do it.
Sure.
And Justin, you've got the shared screen.
Yep, I'll just share it right now, actually, just to get everything ready.
Sure.
You guys you can see my slides there?
Yep.
Great.
Well, we can't delay the presentation. We waited a couple minutes. So welcome everybody to Grand Rounds. Pleasure to introduce, to those who don't know, Dr. Justin Gill, who's one of the transplant nephrologists recently out of the program, come into our division of nephrology. And as you can see by the title, the improving access to kidney transplantation is the topic. So I think we're all interested. Justin, please take it away.
Thanks, Dr. Casson. So hi, everybody. I've met I see some familiar faces and names. As Dr. Casson mentioned, I did my training here at UBC and my nephrology training, and then I went away to the United States to do kidney transplantation at Emory University in Atlanta, and just joined the division this past year. My primary interest is within ethics in transplantation, so we're going to be kind of focusing on an ethics slant around kidney transplant. So hopefully you guys will find this talk interesting. So in terms of, I don't have any financial disclosures, no conflicts of interest, and I just wanted to acknowledge and thank Drs. John Gill and Matthew Caditz, two of my colleagues, for supplying some of the figures and content for this talk. So my objectives today, primarily, I just want to demystify what we do in kidney transplantation. I think that it's kind of a black box for a lot of individuals, especially in general medicine, who don't necessarily encounter us as much. I wanted to provide an overview of the current state of kidney transplantation in British Columbia, discuss ethical aspects of organ transplantation relevant to allocation of organs, and then review our implemented and then also proposed strategies to try to increase access for our patients to living donor and deceased donor kidney transplantation. So this is just a snapshot of kidney care patients registered in British Columbia. Some of you may have seen this data before. I'm sure all the nephrologists on this call know this quite well. But as you can see in the bottom right, there's over 20,000 patients in our province with pre-dialysis or dialysis-dependent chronic kidney disease. To me, this is a staggering number of individuals with chronic kidney disease that are floating around out there. And as you can see, the majority of them are in Fraser Health and Vancouver Coastal Health and Providence Healthcare, followed thereafter by Vancouver Island Health Authority and Interior Health Authority. And around 17,000 of this 20,000 are pre-dialysis. And so really they're looking into modality education, looking into what the next steps for them could be. This table really illustrates that there's been a steady increase in the number of chronic kidney disease patients in the province over the past 10 years. So as you can see in the highlighted numbers here, there's been a 53% increase compared to 2010 numbers in the number of patients living with chronic kidney disease in our province. So with this comes a substantial increase in the demand for renal replacement therapy. And as you can see in the box in the bottom right, there's been a subsequent increase in the total number of dialysis patients by 27% over the same time period. As most of you may know, dialysis is expensive. It's not an infinitely available resource, and it carries significant morbidity at times. And it requires lots of adequately trained and available healthcare personnel to really run effective and efficient programs. Fortunately, we have multidisciplinary kidney care clinics that are aimed at comprehensive nephrology care for our patients that have advancing CKD. They receive care from nephrologists there, specialized nurses, dietitians, pharmacists, social workers. But clearly the numbers speak for themselves in terms of the fact that the demand for such resources like these chronic kidney disease clinics and subsequent dialysis therapy is continuing to rise at quite a rapid rate, I would say. So Canada-wide, the number of Canadians receiving dialysis has nearly doubled over the past 20 years. Currently, about 3/4 of these 23,125 patients are receiving dialysis in-center, which is the most expensive option. The big issue here is that only 44% of Canadians on dialysis survive at least 5 years. So clearly there's impetus to potentially get them off of transplant get them off of dialysis or avoid dialysis altogether if at all possible. As we know, dialysis patients often have a significant burden of comorbidities that may limit their lifespan, and they tend to accrue more complications as they gain dialysis vintage as well. So our multidisciplinary kidney care clinics I've already mentioned aim to catch people early and to slow the progression of chronic kidney disease using a coordinated approach to care. As patients progress towards ESRD, modality education is conducted by our KCPs in a very effective manner, I would say, to get patients educated on what their options are. They're educated on peritoneal dialysis versus hemodialysis versus conservative care management, and also on what we're going to be talking mostly about today, which is renal transplantation. As you might expect, I'm going to be talking about this a lot more and how to improve access for our patients to renal transplants and potentially mitigate some of the dialysis exposure that we're seeing in the patients with CKD. So in terms of kidney transplantation for end-stage renal disease, it truly is the treatment of choice for most patients with ESRD. I say most because not all patients are suitable for transplant, and often we don't get referred a lot of these patients that have absolute contraindications. But most of them, however, are evaluated by our pre-kidney transplant clinics. This is because kidney transplantation offers a survival benefit compared to remaining on dialysis. It offers quality of life improvements, and it also offers substantial cost savings compared with dialysis. Just to give you guys some numbers, there was a cost analysis done on dialysis costs in Canada in 2014. And that showed that there's a $75,000 per patient average annual cost of dialysis in Canada, which amounts to about $2 billion in annual Canadian healthcare costs. And the Canadian healthcare system is proposed to save about $20 million in dialysis costs over 5 years for every 100 patients who are transplanted. So clearly, just not even from a patient perspective, but from a healthcare system perspective, there's significant impetus to get patients transplanted. Now, only a minority of patients have contraindications to transplant, as I mentioned. Those contraindications may be active malignancy, chronic or active infections, substance use issues, non-compliance with care, unstable psychosocial situations, and a variety of others. But again, this is only the vast minority, and most of the patients do deserve some sort of assessment from a pre-transplant side to see about their candidacy. The problem here is that an inadequate supply of donor organs for transplantation is really what is primarily limiting us from transplanting more people. And this leads to a supply-demand mismatch for our patients. And unfortunately, this mismatch can lead to death on the transplant waitlist due to the complications that they accrue while on dialysis. Due to the increasing number of patients in our province with chronic kidney disease, unless something is done to really increase the supply of donors, we're going to continue to have demand outpacing supply here, and potentially even more deaths on the transplant waitlist. Obviously, this is an undesirable outcome in our field, which has the singular goal of transplanting and thus benefiting the greatest number of patients possible. So when we look at, as I mentioned before, 5-year survival on dialysis in Canada is not great at 44%. And so when you look at the fact that patients spend an average of 3.7 years in Canada on dialysis before receiving a renal transplant, obviously there's a significant risk incurred for morbidity and mortality as time goes on with more time spent on dialysis. There is some good news, though, in terms of kidney transplantation. We have seen significant growth in the number of kidney transplants, and they've increased by 41% over the past 10 years across Canada. And encouragingly, preemptive kidney transplantation has also increased by about 31%. Preemptive meaning that patients get transplanted prior to ending up on dialysis. One thing that we're trying to improve is our living donor rate, and the living donor rate has been approximately the same over the past 10 years, which is 16.3 donors per million population across the country. So we'll talk a little bit more about this as the presentation goes on. So these are the transplant numbers in British Columbia. As you can see throughout over the past several years, from 2014 up to 2020, there was steady growth in the number of total transplants in British Columbia. And then since 2017, we've been achieving consistently high rates. What I want to point out that's particularly impressive to me is that the transplant community did such a great job in 2020, especially given all the difficulties encountered with COVID-19 and getting people transplanted. We had to adapt new living donor protocols, including isolation periods and swabs. We had to adapt our kidney procurement and shipping protocols. We had to adapt our deceased donor recipient testing. And we even had to shut down transplantation for a period of time at the start of the pandemic. So I truly feel that even though the numbers look smaller than previous years as they are, it's quite remarkable for an accomplishment in a year that was obviously burdened our healthcare system substantially and also got in the way of transplantation to some degree. The current statistics up till April 1st of this year show that there's been a total of 81 transplants so far this year. And then you can see here that there's 567 patients waiting on our transplant waitlist still. Across Canada, this is data from 2019. You can see that there was 1,789 kidney transplants that were done that year, almost 20% of which were done in British Columbia. And nationwide, you can see that there's still a large number of patients on the wait list. And in 2019, we lost 72 patients on the wait list on dialysis while they were awaiting kidney transplantation. So clearly, we've had ongoing success in the rates of transplant year after year, as I've shown you, even in 2020. But it's important to look at what the actual patient and graft survival is. So are these kidneys actually offering patient survival and graft survival outcomes? As you can see in the tables on the left there, patient survival, these are the rates for deceased donor kidney transplants at the top and living donor kidney transplants at the bottom. It's important to point out that overall patients tend to do quite well. And compared to dialysis, surely they have improved survival rates, even with deceased donor transplantation. On the right, you see graft survival, and you can see that grafts also function quite well for deceased donors and living donors, with 67% of deceased donors lasting out to 10 years and 76% of living donors functioning at 10 years post-transplant. There's a lot of research in the transplant community going into trying to improve long-term outcomes for allografts and keep grafts working for longer. But again, these numbers are quite impressive, especially when considering the alternative. So when you look at Canada-wide data from the Canadian Organ Replacement Register, or CORE, you can see that almost 80% of deceased donor transplant recipients are alive at 5 years, and over 92% of living donor recipients are alive at 5 years. And that's compared to 41% of patients on hemodialysis and 53% of patients on PD. So again, clearly there's a survival advantage to transplantation across Canada, not just in British Columbia. So now that I've shown you some of the transplant rates and the survival benefits of transplant compared to dialysis, the question now becomes, how do we ethically decide who gets transplant and who doesn't? After all, it is a scarce resource that requires distribution amongst a large population of affected individuals. So ultimately, transplantation ethics is concerned with two principles: health equity and utility. When we're looking at health equity, equity attempts to account for disparities and difficulties in accessing care by various patient populations. These health disparities can be things that are avoidable health differences according to race, ethnicity, socioeconomic status, geography, for example, and other characteristics that are associated with discrimination or marginalization in populations. This is one of my favorite illustrations of the difference between equity and equality. So with equity, everybody receives individualized care to bring them up to the same level of health and same level of opportunity. In equality, everybody receives the same level of care, but do not achieve the same level of health outcomes due to the disparities that they had pre-existing. So classically in transplant, disadvantaged groups have poorer survival rates. And so it's the transplant community's job to account for these health disparities in order to give them opportunities for transplantation. So we're going to discuss a lot about health inequities experienced by transplant recipients or potential transplant recipients and how they're addressed in our allocation protocols. Now, utility is defined as doing the best for the greatest number of people in society. So a utilitarian viewpoint really focuses on the greater good and for the greatest number of people. So this is where sometimes a physician's obligation to do their best for a specific patient may be at odds with utilization of a scarce resource on a population basis. So utility in transplant dictates that organs should be allocated in an appropriate manner so that they're used to their maximum benefit. So our organ transplant allocation must really balance equity in terms of accounting for disparities in accessing transplant, and also utility in terms of using the available organs to the best of our abilities. Of course, other ethical principles are involved in transplant, namely ones of distributive justice, which dictates that we must be fair and just in how we distribute these organs, which again ties into addressing inequity. Beneficence, which dictates the importance of doing what's best for a patient, which in most cases may very well be transplantation, but sometimes it's not necessarily transplant that's in a patient's best interest. And finally, respect for autonomy, of course, gives the patient the ability to really voice their opinion about dialysis versus transplant versus conservative care. And that's why modality education happens early in our chronic kidney disease clinics to respect a patient's autonomous choice. So really, there are two options for organ transplant available: living donor transplantation and deceased donor transplantation. Living donors are really the preferred mode of transplant for most patients, as it confers improved perioperative outcomes and improved kidney transplant longevity compared with a deceased donor transplant. When you look at the deceased donor transplant, in terms of living donor transplants, there are related versus unrelated donor transplants, and then preemptive versus non-preemptive. And what I mean by that is, as I previously mentioned, preemptive basically means patients who begin or who receive transplantation prior to initiating dialysis therapy. A deceased donor transplantation comes in two forms: neurologically determined death and also donation after cardiac death. So NDD donors is a brain death declaration that's done by two separate physicians, as our intensivists are very familiar with. This is absence of any confounding metabolic abnormalities, absence of brainstem reflexes, and appropriate apnea testing. And they may require ancillary testing like radionuclide angiography to confirm brain death in certain situations as well. Donation after cardiac death is a modality of kidney transplantation and donor approval that has really come into more favor over the past several years and has been used more and more. So I'll show some data on that. DCD kidneys involve withdrawing life support measures, including pressors, ventilation, dialysis, and anything else that's supporting their lives while in a critical care environment. And then we monitor them for a period of time awaiting circulatory arrest with a minimum of a 5-minute observation period from the beginning of the onset of circulatory arrest to ensure that this is irreversible. So this is in British Columbia. Our system is an opt-in system, so people must provide explicit consent for organ donation. This is an example of an organ donation consent form that is to be signed by a family member for a potential donor. As you can see at the top there, there's an indication to say which organs they specifically are consenting to be retrieved. Or in part 2, there's an option for patient families to consent for the organs to be used for education and research purposes in the event they're not usable for transplant. So this is a slide to just congratulate British Columbians, because as you can see, we've had a substantial increase in the number of registered donors in British Columbia over the past several years. And so currently we're sitting at about over 1.5 million people registered to be an organ donor. And as you can see, there are numbers that steadily increased year after year from 2014 onward here. Accordingly, we've had a consistent increase in the number of hospital referrals of donors year after year. And this is thanks to the incredible dedication of our hospital physicians, and particularly our intensivists, who continue to identify potential organ donors that may be suitable for potential donation to our recipients. So under the Human Tissue Gift Act of British Columbia of 1996, any impending donor death occurring in any BC hospital, any impending death occurring in a BC hospital is required to be reported to the organ donor referral line. After the impending death is reported, BC Transplant then works in conjunction with the hospital and the physicians to determine donor suitability for potential transplantable organs. There's been a lot of pushes from the transplant community to incorporate organ donation discussion into end-of-life care. This is a prompt called GIVE, which basically, as you can see there, indicates grave prognosis, intention to move towards comfort care, patients ventilated, and their eligibility and registration is then assessed. And so, as you can see at the bottom, BC Transplant provides various details that physician may be asked for when calling to refer an end-of-life patient for potential organ donation. Now, across Canada, you can see as well that the number of deceased donors that have come up per year has also continuously increased. So this gray line here with the open dots is all deceased donors, and so you can see there that that's steadily risen over the time course of the last 10 years. As mentioned, the living donors, which is stipulated by the dotted line here in purple, the rate has been relatively stagnant over the last 10 years. And so there hasn't been much growth in terms of living donation per se. All that to say, nationwide, we continue to improve year after year in identifying donors and referring them for consideration. So the question now becomes, how do we appropriately allocate these kidneys? And that's what we were talking about in terms of equity and utility, in terms of ensuring that we're accounting for both in allocating these organs for transplantation. Now, our kidney transplant waitlist is organized by blood group, and a patient's time on the waiting list begins when they initiate dialysis. And this is specifically the waiting list for a deceased donor kidney transplant. The reason that we start from the dialysis initiation date is that it accounts for the inequity that may be experienced in terms of referral practice. So some patients may be referred after dialysis initiation by some centers, versus some patients may be referred before dialysis initiation. And in any case, the patient should not be penalized for any time lost waiting to see transplant physicians. So we backdate their time on the transplant waitlist to their dialysis initiation date. Priorities on the transplant waitlist are assigned to address our inequities that we see in our transplant patients. So first off, urgency prioritizes saving the most lives. So for example, some of our hemodialysis patients have minimal vascular access options left, and they're on hemodialysis kind of on their last access, and they're waiting a transplant. This really recognizes that not all recipients can wait the same amount of time. So medical urgency does take priority in certain circumstances. The highly sensitized, or HSP program, is a national system, and I'll talk about that more in depth shortly, but it tackles inequity in access to transplant due to immunologic barriers specifically. So patients that have a high degree of anti-HLA antibodies that make them difficult to match, we then enroll them in a national system that will potentially address these immunologic barriers by increasing their access to a donor pool that's across the country, not just specifically within our province. So this contributes to justice in kidney transplantation on a national basis. We have pediatric patient priority, which again accounts for the fact that pediatric patients have many functional life years ahead, and they have a significant survival benefit from getting transplanted versus staying on dialysis. Combined organ transplants are also prioritized, and this takes into account the inequity that may occur from requiring more than one transplant at a time. So by prioritizing them, the kidney kind of comes along with other organs that may be prioritized based on acuity. So for example, as many of you may know, liver transplant, heart transplant, and lung transplants, it's essentially the sickest people get transplanted faster. as opposed to waiting in line as they often do with a kidney transplant. And so these patients that need a combined liver kidney, for example, are prioritized for transplantation. Patients that were previously a living donor are prioritized, and this is because while their previous donation of a kidney did not necessarily cause their end-stage renal disease, it's thought to have contributed to their kidney failure from whatever did cause their kidney disease in the long term, because they only have a solitary kidney left. And so this is a kind of reciprocity-based strategy where we're accounting for the inequity of their previous donation, and patients are paid back with priority on our deceased donor transplant waitlist. And then finally, we get down to patients who just waited the longest on dialysis. So this is kind of where it moved from equity to equality. So this is basically patients, whoever's waited the longest after the priority patients are assigned, they wait in line, and whoever's been on dialysis the longest gets transplanted first. Now, obviously, as we've talked about before, there is accounting for some inequity in referral practices by backdating to their dialysis initiation dates. But again, at the end of our allocation system, it all becomes about equality rather than equity. So just to say something more about this, although it's arguably much more complex, the American kidney allocation system was revised in 2014 in an attempt to improve access to transplant. And so this system also tries to address disparities, including similar barriers that we've addressed here. But they also incorporate other parameters into their kidney allocation system. So specifically estimated post-transplant survival for patients, and also donor quality indexes of the kidneys themselves. So the American system really works at maximizing, or tries to work at maximizing utility, and so to using the organs available in the best way possible, because they have much more of a significant supply-demand mismatch compared to us in Canada. So there are several steps in terms of addressing our access to kidney transplantation issues. The first step is really in the referral. So there are several steps required before a patient can get to transplant. The first step obviously is referral to a transplant center. The next step is the transplant evaluation stage, where we actually see patients and we do extensive testing. Then we look at patients who are on the wait list, and then they're awaiting allocation of organs. And then thereafter, the transplant stage is the final step there. And that's where we aim to get all these patients in BC who have chronic kidney disease. Ideally, we want to get them to this last stage as quickly as possible. So talking first about inequities in terms of referral. So this is a publication from 2019 by Kim et al. Published at Jason. And John Gill, who's one of my mentors and colleagues, is one of the co-authors on this paper. And basically this shows that only 17% of incident end-stage renal disease patients across Canada were referred within 12 months of dialysis initiation to a transplant center. So in Canada, access to a transplant requires referral from a nephrologist. In this study, obviously, there's clearly an inappropriately low rate. You can see here there's the rates per province, and this is referral rate per 100 patient years of dialysis for each region. So the question is, why is the referral rate so low? Only 10 to 15% of patients have the absolute contraindications to transplant, which we've already talked about. So even if you look at, if somebody's saying, will they survive 5 years or not, even if you look at 5-year survival, we should at least be seeing 50% of dialysis patients be referred quickly to a transplant center, even if you're looking at just 5-year survival outcomes for these patients. So these referral rates are similar to the state of Georgia, where I did my training, and that has one of the lowest transplant rates in the United States. So I think there's a lot of room to move here, and we can do a lot better in terms of referring patients early. Now, this variability may be related either to nephrologist knowledge about the transplantation process, about maybe preemptively deciding if patients are candidates or not, which is sometimes appropriate in certain circumstances. It may be due to the increasing separation between transplant centers and community centers. It may be due to inadequate patient education prior to starting dialysis in certain centers. So this really needs to be addressed by creating some standardized referral processes and ensuring appropriate education, and then potentially ongoing audits of referral practices. In the US, they've looked at incentives and penalties for referral practices. That's not something we've instituted here as of yet. Now, in this study, factors that were associated with a lower likelihood of referral mostly make sense. So older patients were referred less, diabetes-related end-stage renal disease were referred less. Often they have many other comorbid medical conditions. And then patients who, one thing that I don't think should deter patients from seeing a transplant center, but unfortunately is the barrier, is the geographic barrier. So people who dialyze more than 100 kilometers from a transplant center had a tendency to be referred less for transplant. So clearly there's some work to be done at the referral stage. Once we actually get to the transplant evaluation stage and we have patients referred, there's been a significant issue with marginalized populations actually accessing transplantation care. So as we all know, due to globalization, Canada's population has become significantly diverse, and we have 21% foreign-born individuals in Canada. 22% of Canadians actually identify as a visible minority. So we do know from various research that Indigenous, East Asian, South Asian, and African Canadians are less likely to receive kidney transplants compared to white patients. And Indigenous populations specifically are 50% less likely to get a transplant themselves. And so current organ donation and transplant practices and education don't appropriately take into account cultural, religious, spiritual, and socioeconomic context of these marginalized and minority populations. So thus, these patients have had significant issue with accessing culturally safe care. So I just wanted to touch on a couple of initiatives that the transplant community here in BC has started up to try to improve these barriers to access for patients. So the Bridge to Transplant initiative, it stands, as we all know, we all love acronyms in medicine. So Bridge stands for BC-wide Program for Indigenous Communities to Gain Equitable Access to Kidney Transplantation. And this is designed to really create a culturally tailored education and donor outreach program, and that will potentially streamline recipient and donor evaluations for Indigenous patients with a single paid visit to Vancouver as opposed to several serial visits over time. And then to try to practice cultural safety by engaging in respectful partnerships with Indigenous communities, and specifically by involving elders and traditional knowledge holders. So that's ongoing and been piloted by Dr. Jag Gill, and I've been involved in that as well in terms of the working groups. Similarly, the ACTION project, which stands for Improving Access to Living Donor Kidney Transplantation in Ethno-Racial Minority Communities in Canada. This is specifically looking at addressing South Asian, Black, and African and Caribbean population access to transplant. This project aims to engage patients and community partners to identify cultural gaps in care and create culturally competent education materials to ultimately inform kind of broad implementation strategies to improve our access to transplant for these patients. So clearly there's some work to be done once patients are even referred, but there is ongoing work in this area, which I think is quite impressive and hopefully will yield some good results over the coming years. Now we get into the more of the complexities around who gets organ transplants and how do we appropriately allocate them. As I mentioned, we talked about equity and utility of organ transplants. So how do we address some of the concerns that we've already talked about? So one of the issues that we aim to address nationally is the immunologic inequity that is experienced by patients. So patients who are highly sensitized, meaning they have a high degree of anti-HLA antibodies that make them immunologically difficult to match for a donor kidney. These patients, as I've talked about already, are prioritized on our deceased donor transplant waitlist across the country. And so the HSP registry is a national registry that's run by Canadian Blood Services that was implemented in 2013. And then all provinces were participating in the program by the end of 2014. As you can see in this figure below from the Canadian Blood Services website, we've had a total of 693 highly sensitized kidney transplants since the conception of the program. And this impressively includes 405 interprovincial transplants. So for example, a donor kidney came up in Manitoba for a recipient in British Columbia that's highly sensitized. And so that's what it means by interprovincial. I think this is remarkable, and it really addresses the disparity in access in kidney transplant for those who are immunologically complex and really improves their access to transplant overall. Because some patients who have a high degree of these antibodies may wait for many, many years without getting a single offer for transplant, despite being on dialysis for sometimes upwards of several years, even up to recently I got an offer for an HSP patient who's been on dialysis now for over 12 years. So this program obviously improves their chances of getting an offer. Now, to show you that this has actually been beneficial, this is some American data that was published in 2016, and there's a new kidney allocation system, as I've already mentioned, that came into effect in America in 2014. that prioritized patients that were highly sensitized. As you can see here, the percentage of patients who are very highly sensitized who are getting transplanted was very low year after year, down to 2.4% prior to the kidney allocation system being revised. And then all of a sudden, after it's been revised and we're starting to get increased offers for patients who are very highly sensitized, there's a sharp rise from 2.4% to almost 18% of these patients getting transplanted. So clearly there's benefit in addressing this immunologic inequity by creating national programs to increase their transplantability. Other ways to address immunologic inequity is another national program that I'll touch on, specifically with regards to living donors. So this is another initiative from Canadian Blood Services called the Kidney Paired Donation Program, or KPD. And this was a national registry that was implemented in 2007. So just to walk you through this basically improves access to living donor transplant for incompatible pairs of patients. So as you can see here, let's say incompatible pair A, let's say that they're in British Columbia, incompatible pair B is in Alberta, and incompatible pair C is in Ontario. As you can see, if they all get registered in this KPD program across the country, the donor from incompatible pair A can donate to the recipient B, the donor B can donate to recipient C, and donor C can donate back to recipient A. Therefore, this creates a series of transplant chains that trigger multiple transplant events around the country. Since its inception, the program has accomplished 790 transplants completed through the program, and 492 of these have been remarkably through a domino effect from a non-directed anonymous donor. So if somebody altruistic just comes up and wants to donate a kidney to the general pool, the best way in terms of benefiting the largest number of people is that they can donate to the kidney paired donation program, and therefore potentially have the ability to increase to get several people transplanted across the country by kicking off the chains. So there are several possible ways that we could use the KPD system to increase living donor transplants further. Now, this is not stuff that's currently enacted for the most part, but it is stuff that has been thought of, and these initiatives are active in the United States as well. So they're interesting to talk about. There's been the concept of voucher donors. So patients who have thought to be chronologically incompatible. So let's say a donor and a recipient, there's a donor and a recipient. The recipient isn't necessarily yet ready for transplant. Their GFR is in their 20s or 30s, but the donor is getting older and wants to donate in advance, just as a sort of in advance until, they don't want to wait until the recipient gets to the point where they need dialysis, because they may no longer be able to donate at that point. And so they donate in advance and provide a voucher for the patient, such that when they require a kidney transplant, they can receive a kidney transplant as an end of chain recipient in the kidney paired donation program. In the United States, just to show how this has worked, the first 3 voucher donor cases triggered 25 total transplants through paired donation chains across the United States. So clearly, this program that launched in 2016 in the US has seen significant success. So it's a possibility for us to improve our living donation rates here. Similar to this is a family voucher. This is donation in advance, but the donor actually doesn't know anybody who necessarily needs a transplant right now. So they're giving a kidney altruistically, but they're able to name individuals who, if they need a kidney transplant in the future, could then be prioritized for one through the kidney paired donation program. So this was set up in the United States in 2019 through their National Kidney Registry, and has been up and running since that time. And that program allows patients or donors to name 5 people that could potentially be prioritized for transplant later, should they require one. One of the interesting ways in which we could potentially use the kidney paired donation system to improve access to living donation for patients across the country is by actually enrolling compatible pairs. What I mean by that is that in this schematic here, donor 1 can donate directly to recipient 1 here in BC, but altruistically they decide to enter the kidney paired donation program, and therefore instead of 1 transplant occurring, this has benefited 2 transplants have occurred. So donor 1 actually donates to recipient 2 because they're compatible, and donor 2 donates to recipient 1. So patients who altruistically, or pairs that altruistically enter kidney paired donation could see some benefits. For example, recipient 1 may receive a kidney from donor 2, which potentially could be a younger kidney, a better size match, or maybe even better immunologic matching. So there are potential benefits, but really this is a purely altruistic process. And then finally, there's been some organ donors that were potentially deterred by the fact that they had to previously travel for the kidney pair donation program. So what we used to do is that we used to get donors to travel to the recipient site to undergo donation, and then the recipient stays at their home site. Clearly, so that would deter some individuals. Some non-directed anonymous donors didn't want to travel, just wanted to get it done in British Columbia. And so, for example, that did limit sometimes people's involvement in kidney pair donation programs. However, during COVID, we were kind of forced to not get people to travel, of course, because we didn't want to expose potential donors to the risk of COVID-19 on airplanes and on trains. So there's been a collaboration between Canadian Blood Services and Air Canada to ship our kidneys for KPD purposes across the country. So donor can be in Ontario, for example, for a British Columbia recipient through KPD. The donor surgery is done in Ontario, the kidney flies here, and then gets transplanted here in British Columbia. So this is probably something that may continue post COVID and potentially could increase the number of people that are interested in participating in KPD. Other ways that we could improve access to living donors. So there's been a big push from the transplant community to ensure financial neutrality for donors. So specifically, a donor should not incur any expenses from transplant, nor should they receive monetary gain from donation. So the purpose here is to really eliminate financial disincentives to transplant. And this means reimbursing out-of-pocket expenses, lost wages, for example. And so here in BC, the Living Organ Donor Expense Reimbursement Program is administered by the Kidney Foundation of Canada, and this reimburses donors for eligible expenses, including their travel, accommodation, meals, parking, and then also potential loss of income. But patients still may incur costs to donation because there are criteria and there are reimbursement limits, etc. So to address this, one of the initiatives put forward by the American Society of Transplant and now partnered with the Canadian Society of Transplant is something called the Living Donor Circle of Excellence. This program offers to eliminate financial costs of living organ donation by partnering with companies who will support living donation through providing lost wages, so a minimum of 80% of salary support for a minimum of 4 weeks. And then these companies are subsequently recognized by the AST and CST with annual certificates on the CST website and social media platforms, and then also promotion at major transplant meetings and events. The current members of this program in Canada include PHSA, Paladin, and Pacific Coastal Airlines, and the number continues to grow. So this is an excellent initiative and hopefully will ensure more financial neutrality for donors as time goes on. An interesting piece of legislation in the US is important to note. We don't have legislation here specifically because we have a public healthcare system, but in the US, as everybody knows, there's a public-private mix and with a lot of different stakeholders, including various insurance companies. And so the US Living Donor Protection Act is a 2021 legislation that's been proposed that protects living donors from high insurance premiums that may be incurred, and then ensures coverage under the FMLA, which is Family Medical Leave Act, and thus removing some financial barriers potentially to donating in the US. Right here at home in BC, we do have the Transplant First initiative. So this is promoting preemptive transplant before patients end up on dialysis. And this is really a BC program that's been dedicated to increasing awareness of preemptive living donor transplants prior to dialysis initiation. A lot of this happens through our kidney care clinics. As I've mentioned, their multimodal education sessions do address our Transplant First initiative. So we kind of have to push to keep educating our patients on the benefits of living donor transplantation and avoiding dialysis altogether, if at all possible. So just on the last part of this talk, I'm just going to switch focus into how we best use our deceased donor organs that are available for transplant, because this is another way in which we can improve access to transplantation by making sure we use the most deceased donor organs that we possibly can for the most patients. So as I've mentioned, donation after cardiac death donors have become much more frequent over the last several years. This is Canadian data, and as you can see here, DCD kidneys, which is delineated by the dark red line at the bottom, has increased substantially in transplantation rates over the last 15 years or so. And that's because they have excellent outcomes and should not really be considered marginal in allocation. We have increased use of ECD kidneys, or extended criteria donation kidneys. And these are kidneys that are from donors who are above the deceased donors who are above the age of 60, or patients who are between the ages of 50 to 59 with at least 2 of hypertension, a terminal serum creatinine greater than 133, or death from a cerebrovascular accident. These kidneys have a higher rate of discard in the United States because they're considered more marginal, but we do find that they provide a survival benefit, especially in older patients. So while they do have inferior graft survival compared to non-ECD kidneys, they can be appropriately utilized in older individuals who are awaiting transplantation. And so we routinely use ECD kidneys, especially in our older kidney transplant recipients in BC with very good outcomes. So this has been a significant push towards improving our use of deceased donor organs. We also have increased use of what we call exceptional distribution kidneys, or ED, which are increased infectious risk kidneys. So these are increased risk donors that have potential to transmit infectious disease to a recipient. ED is really a Health Canada designation, and this includes donors, for example, who have a history of intravenous drug use, previous sex work, unknown sexual history, or if they've been incarcerated, for example. There's a variety of stipulations as to what qualifies a donor to be ED. And patients need to be consented for this because the risk of infection is there. We do NAT testing for HIV, hepatitis C, and hepatitis B in all of these donors. However, there's also window periods for infection. So the risk of transmission of disease remains, and it's variable depending on the risk activity. So for example, for HIV transmission from an IV drug user, the risk is up to 1 in 4,000 in the literature, despite NAT testing. And then for hepatitis C, for example, the risk is up to 1 in 250 for active intravenous drug users, given the window period. So as an aside note, just about hepatitis C kidneys, we're actually now routinely using hepatitis C positive kidneys for transplantation and treating our patients with direct acting antivirals post-transplant to cure them of the hepatitis C. So this program has had great success in British Columbia, and now we've seen quite a few people who've been transplanted with hepatitis C positive kidneys who have achieved SVR after treatment. Patients are then routinely, if they get an ED kidney, they're routinely followed up with blood work at regular intervals post-transplant to ensure that they remain negative. And then, as we all know, MAID legislation came into effect in 2016, and this is federal legislation around Canadians seeking medical assistance in dying. And in the same year, organ donation after MAID was also established using a modified DCD pathway. So the first MAID case in BC was completed in the first MAID transplantation case in BC was in 2017. And currently in BC, the only stipulation is that the MAID process has to take place in a hospital setting in order to facilitate organ donation. But it's important to note that the MAID team and the transplant teams are entirely separate. And again, it's just about incorporating, as we've already talked about, organ donation into end-of-life care. Now, there have been lots of efforts to look at how do we actually improve transplant rates in terms of registering potential donors. So as I already showed you, BC has had steady increases in their number of registered donors year after year. There's been thoughts of using something called nudge theory, which are kind of just questions at the top of a registration form saying things like, what would you do if you needed an organ or if a loved one needed an organ? And these nudges have been shown to be quite effective in getting people to sign up as potential organ donors. Other countries like Israel use strategies like prioritizing people who have signed up as an organ donor if they actually need a transplant themselves. So it's somewhat like a reciprocity-based strategy. But one hot topic of debate in transplant is one of opt-out consent systems. So this is a consent system that's employed in countries like Spain, the UK, and Belgium. There's been success in improving donor rates, but the true transplantation rates have really been a mixed bag when comparing opt-in versus opt-out systems. And it looks as though in recent literature that opt-out systems may actually reduce the living donor transplant rates overall, which obviously, as I've mentioned, living donors are the preferred mode of transplantation, so this may not have a desirable outcome in that way. Now, regardless, Nova Scotia has become the first Canadian province as of January of this year to enact an opt-out legislation or presumed consent. So as of January 18th, the Nova Scotia Human Organ and Tissue Donation Act states that if you don't register your donation decision and you are eligible, you'll be considered as having consented to an organ and tissue after donation, for donation after death. So basically, if you haven't opted out, you'll be considered an organ donor. Certainly, an opt-out system has ethical issues, including the potential for exploitation of donors, the question of whether presumed consent is the same as informed consent, and then further marginalization of vulnerable populations. So we'll see how things work out in Nova Scotia. I mean, it's a good litmus test to see how this kind of legislation could work in the rest of the country and potentially other parts of North America as well. And it's a hot topic in the news right now. As you can see, there's various headlines, even when you just Google Nova Scotia opt-out, various headlines addressing the issue. So finally, I just wanted to talk about patients. So once they actually get to the transplantation stage, we get them transplanted, we get them off of dialysis, everything's going fine. Ultimately, patients do have allografts that fail. And I did talk about long-term failure rates earlier. And so what happens when patients need retransplant? So referrals for retransplant are often made by the transplant center itself. So patients don't have issues with accessing retransplantation per se. But the question then becomes, should patients who have never had a transplant before be prioritized over a repeat transplant recipient? And so this is US data put together by Clark et al. In 2019, and Jason and Matthew Kaditz, John Gill, and Jag Gill from the UBC, from my colleagues and from the nephrology group here, were authors on this paper. And as you can see at the top, this is US data that shows a higher proportion of failed transplants are receiving deceased donor transplants than incident ESRD patients. So this may be referral bias again, so the fact that that transplant centers are often referring these patients for retransplant. But the money here is really in the bottom graph, which shows that the relative risk of death in incident ESRD patients and those with failed transplants compared to remaining on the wait list. So the dotted line here that's across the middle is the baseline, which is remaining on the wait list. And as you can see there, by about 50 days post-transplant, there is a significant survival benefit for both groups. So when you're looking at whether incident ESRD patients should be prioritized over repeat transplants, I mean, the bottom line is both groups benefit, and so one shouldn't be stratified over another. There is substantial mortality benefit in repeat transplant patients to getting another kidney compared to remaining on dialysis, because the highest mortality risk after a failed transplant is in the first year back on dialysis. So just something to consider when we're moving forward and looking at retransplanting these patients. So I just wanted to summarize, and then I'll open it up for questions. As we talked about today, there is an ongoing growth in the number of patients living with chronic kidney disease in British Columbia and nationwide. Kidney transplant offers quality and quantity of life benefits, so the number of patients waiting to receive an organ on the wait list remains unacceptably high. Allocation systems for organs must center around balancing equity and utility to the best of their abilities. And improving access to kidney transplant involves addressing our referral rates, barriers for marginalized communities, immunologic disparities, increasing our living donation rates, and increasing usage of our available deceased donor kidneys for transplants. And the ultimate goal of the transplant community and the nephrology community at large is really to alleviate the critical shortage of organs for transplantation and reduce waiting times to transplant, and also reduce time on dialysis. So I'd be happy to take any questions, and if anybody wants to email me with questions, that's my email address there as well.
So thank you, Justin. And as moderator for the grand rounds, I'm going to take the opportunity to ask the first two questions. The first is a very simple question. In the map that you showed us of people being alerted for transplant, Quebec didn't have any numbers. I didn't understand that. Maybe you can explain that. And the second question, which I think is maybe to me more interesting, is how often do we call it right? So in terms of, you've made a plea for and a correct plea for the availability of transplant, but how often does the transplant community say at the end of a successful transplant, this is a person that didn't benefit from the transplant, we shouldn't have transplanted? And maybe you could address both of those.
Sure, yeah, those are great questions. In terms of why Quebec is not included in some of this data, maybe I can defer that. I actually don't entirely know myself. I think it's just an issue around data collection on a national basis, but I might be able to refer that to one of my colleagues after I answer your second question, Barry. So in terms of why, how many times do we get it right versus how many times do we get it wrong? I mean, there's a handful of patients, all the time that potentially do not receive the benefits offered with kidney transplantation. And we do our very, very best to risk stratify patients prior to transplant, specifically around cardiovascular disease, malignancy, and seeing whether or not they can tolerate not only the perioperative period, but also the post-transplant period with all of the new immunosuppression drugs. So our goal, as I've talked about this during this entire talk, is to get people transplanted as effectively and as quickly as possible. But really, we have to also be looking at candidacy. And candidacy, for the most part, is that we try to make it as objective as possible, but often there's a lot of subjective components to it as well. And so I would say the times that we say, hey, maybe this wasn't in the patient's best interest is the vast minority of cases. There's always cases that don't go as planned with perioperative cardiac events, for example. But I would say that that's the vast minority of cases.
Thank you. Please, there's a couple in the chat box. Let me just see.
Barry, while you're doing that, this is Jag. I can address the Quebec question really quickly. So it's just, it is, as Justin said, a data acquisition issue. There were for many years privacy issues of sharing that data nationally out of Quebec. Thankfully, it's all rectified, so that should be better in the years to come.
Good. And from the chat box, one of our senior residents, are you seeing differences in the demographics of donors that you see in recipients? That is proportionally low recipients who are East, South Asian, Indigenous, etc.
That's a great question, Brian. We are seeing lower rates of donation depending on which group you're considering. So, for example, the ones that you've mentioned, Indigenous populations and South Asian populations, have notoriously had lower organ donation rates compared to, for example, Caucasian population. And so that's why there's been a lot of effort in the Bridge and the Action initiatives to try to improve access to living donor transplantation, not only by improving recipient knowledge of the process, but also by improving potential donor knowledge of the process and the public at large, to try to get people educated and to truly understand the risks and the benefits of donation and of transplantation.
So any other questions, comments for Justin?
Barry, it's John. I have a question for Justin, but I know the answer to it. I just wanted to have the discussion go there. But the last point is really an exceptional one. I think that, you know, one province in Canada has now gone to a presumed consent form of deceased organ donation. And what Justin, you know, didn't identify is that most of our organ donors, we've had an opioid epidemic, are the most marginalized patients in our population. There are issues with trust, systemic racism in the healthcare system. And so our job really is to educate and empower those potential donor families to make an informed decision about organ donation in this province. And I think we've been very successful in doing that. For sure, there's work to go, but I don't think we should get hung up on very crude metrics such as race and ethnicity, because really we need to ask ourselves, what's the level of trust? Are we doing a good job in addressing those concerns, which are impediments to organ donation? Because if you think about it, it's a huge amount of trust with donor families. And I just wanted to add that commentary. Just briefly, I wanted to ask you about the use of older individuals as living donors, because that's one of the major things that we're doing, and wanted to get your thoughts on that.
Yeah, so I think using older donors as older living donors is definitely possible, and we're seeing more and more people who are coming forward at an older age as potential living donors. I definitely think it's possible, it's feasible, and we've seen people coming forward for this. I mean, just recently we've done a 76-year-old donor donated directly to her husband, who's doing excellently. So definitely, I don't think that there's age cutoffs. There's no specific considerations for that population. We're just really looking at how well is that donor kidney from a 70-something-year-old, for example, going to do in its recipient. So how good is the function, and what is the likelihood that that person can last with that one remaining kidney for the next 10, 15, 20 years of their life. So definitely, I agree with you, John. I think it's a great thing that we're getting older donors coming forward, and I just think it comes down to how we use their living donor kidney effectively.
Just a comment. I mean, that must be very unusual, but I hope you're making the public aware of that very, very special situation where a partner at that age donates to their other partner. That says a lot about everything. So sorry to take that away. Other questions, comments? I have some in the chat box. Let's see. I don't know, it seems, sorry, does it seem to affect organ match? Like, do people with ethno-racial group have better HLA compatibility? And is that why there's a lower rate of transplantation within these patient groups? I think this is from Brian Kim as well. He seems to, yeah, I think he's generated this. So do you want to answer those?
Sure. I mean, in terms of why we see potential lower donation rates in certain groups, I don't think it's necessarily related to HLA compatibility. I mean, within ethno-racial groups, do we see higher rates of HLA compatibility? I would say it's a complex question, but yes and no. We often see higher rates of HLA compatibility between related donors, for example. So a father that wants to give to his daughter, maybe a one haplotype match, so they have better immunologic matching. So in those certain circumstances, yes, the HLA compatibility will affect somebody's long-term allograft outcomes and their risk of rejection. But within our ethno-racial groups, I don't think it plays in a large degree in terms of their ability to donate. And that's not necessarily why there's a lower rate of transplantation within these marginalized patient groups. I think it's mostly around the rate of, around issues as have been mentioned in terms of systemic racism, marginalization, inability to access care, and also a lot of the times, unfortunately, their comorbidity profiles and the preventative care that's been offered to them. So poorly controlled diabetes, heart disease, hypertension, strokes, unfortunately disproportionately affect a lot of our marginalized populations like Indigenous patients. So I think it's more so to do with their medical and their social context rather than their immunological basis.
It's just at the end of the hour, so I'm sorry I've really monopolized the question period, but I do have a question for the whole team. And that's in Nova Scotia. I guess they just started this program. Have there been, have families taken issue with the fact that people are now are donating organs when there was no written consent? So has there been any challenge by families, and perhaps here as well, for organ donation?
That's a great question, Dr. Hassan. I actually don't know myself. There's been I think one of the publications I was reading from one of the news outlets was saying that there's been a higher rate of opting out than they expected, but I don't know exactly what number that entails and what amount they were expecting. But maybe if one of my other group members knows this.
Barry, I guess it's Jag. So there is data collection ongoing in terms of that. But I think the major point, and John had alluded to this earlier, is that the issue with presumed consent versus informed consent is a pretty tricky one. I think places that have incorporated presumed consent have really had to put in a series of infrastructure changes to support presumed consent legislation. Where if you look at a province like BC, where 15 years ago we had the worst deceased donation rates in the country, and without presumed consent legislation, you just invested in that infrastructure, working with intensive care units, you saw a threefold increase in deceased donation rates. And so whether there'd be significant value add with presumed consent legislation in our province, personally, I'm not convinced, right, that there would be, but that's the big question. And that's where I think what John was alluding to earlier is you have to consider the downsides of presumed consent in terms of making sure that you're not, impacting that trust relationship between the healthcare system, and particularly in racialized communities, I think is a big deal.
Good. Thank you very much, Justin. That was excellent. It was an excellent review, and thank you for presenting. Thank you to the transplant group and to nephrology. And in case people haven't had enough nephrology, VGH Grand Rounds next week will be presented by the Division of Nephrology. They've yet to assign a topic, but we're looking forward to it. Thanks to everybody for attending. We'll see you next week.
Thank you.